to the medical students at Auckland University. And in that teaching, we use cases quite a lot. We discuss cases. And so what I want to do with this session is to introduce a case that routinely causes the students to ask a lot of questions, because it poses a real conflict. And part of the interest, I think, of this case is it's not one of those kind of extravagant ethics cases that happens, once in a blue moon. It captures the kind of dilemma that I get the impression that most professionals feel and experience and have to deal with in some kind of way in their everyday practice. So I'll start by telling you the case. It's a case involving a young woman, she's 23, her name's Veronica, and she comes to you just on the brink of going to America on this prestigious scholarship that she's got in engineering. And she comes from, she's had quite a sad background. She's had a difficult upbringing. Her father was violent in their home, and in the end he was imprisoned, and she lived with her younger brothers and her mum on not very much income at all. So life was pretty tricky for her. So it's all the more creditable that she's managed to overcome these concerns and get this. She's done fantastically well in her Bachelor of Engineering, and now she's got this scholarship. So she comes to you because she's been having various symptoms which you think might be polycystic ovaries. And she needs to go for a scan, and you need to grade her this request for a scan. And there are rules around this, there are guidelines. And according to your assessment of her physical symptoms, she wouldn't qualify as an urgent case. And if she doesn't qualify as an urgent case, she's not going to get seen at least for 3 weeks, let's say, 3 weeks or 4 weeks. But she's got to be at this university in 2 weeks, or she loses her scholarship. She forfeits her scholarship. Now, on the conditions of her trip, she doesn't have any recourse to healthcare cover through her scholarship or through her university, and there's no way that she can afford to pay healthcare insurance. So if she doesn't get the scan now, she's not going to have any treatment for the next 2 years. How do you grade the case? Do you grade it according to her physical symptoms, which are not hugely urgent, or do you grade it in a way that finesses your true view, allows her to get her scan in time for you to have some treatment in place for the next 2 years? So I'll be interested to hear whether you think that this is something that you guys are doing all the time, sort of bending the rules, interpreting the rules in a way that is good for your patients. And of course it's no surprise that doctors do this. It relates to this very deep conflict that we as a society, as a profession, have written into your role. So there's this conflict between your therapeutic obligation to the patient, the kind of obligation that's sometimes represented as one of beneficence or non-maleficence, perhaps, the welfare-related obligations, where the interests of your patient are paramount. They are your prime concern. That's one set of obligations. And then there's your obligations to behave justly, to carry out your role in a way that's fair to everybody. And of course these things conflict. So how do we handle the conflicts? Well, what I want to do now is to lay out several approaches that we might take. They're essentially mini arguments, and I've got 3 arguments about what we should do when the rules don't produce the most beneficial or maybe even a satisfactory outcome for your patient. And I'll present an objection to each of those, and then I'm going to end by presenting you with a number of factors that I think are relevant in determining whether it's acceptable to break a rule. And then I want you to, tell me why I'm wrong, essentially. Okay, so when we think about justice and the requirements of justice, we need to have some kind of root in here. We need to know about what justice requires from us. And I like to start with Aristotle. Why not? Why not start with ancient Greek? And he produces this formal principle of justice, which is treat equals equally and and unequals unequally in proportion to the relevant inequalities. So this is a nice benign type of principle that we can all agree about, can't we? We should treat equals equally, treat unequals unequally. How do we work out who's equal and who's unequal? This is the problem that we face, and there are multiple attempts to do this in political philosophy. We're not going to get into political philosophy, so don't worry. We're going to think about this in the specific case that I've presented. So here's version 1 of what Aristotle's principle might require of us. Equals in the health system are people who have an equal health state. This is the first claim. This is the way we have to do it in health, because we're not a service that's about dishing out fair allocations of resources generally. We're not a system that's about making sure that people have a fair go, that they get to live a good life. That's not the role of doctors. The role of doctors is to administer to health states, to treat health states. So there might be reasons in general for society to care about these things, but we've got to compartmentalise because of the nature of our expertise and because of the nature of what we're doing. So an equal, according to this argument, in health is somebody with an equal health state. In terms of Veronica, that means that we ought to apply the rule, because the rule is about grading physical symptoms, and so in grading physical symptoms, we treat equal health states equally, we behave justly. So this is the first version, and it amounts to saying, follow the rule, because the rule is just. Might not produce the most beneficial outcome for Veronica, but it's a just outcome. It's a just application of a just rule. That's version number 1. Here is an objection that you might make to version number 1. Sure, there are a range of health states, and that they differ, and we might be able to grade them precisely in some cases. But that's to forget about the fact that a single health state can have a really differential impact on one person's life than on another person's life. So health states might be some kind of proxy to equality, but they're not a very reliable proxy, because we know that some health states are just harder to bear for some people. And that might be for a range of different reasons. It might be because they have less recourse to private funds than other people do. It might be because they have more responsibilities that press upon them than others do. It might be because they're more anxious people and they find it harder to deal with certain things than other people do. But whatever the reasons are, we know that health states don't affect individuals in the same way. And if we avoid that, if we pretend that that's not true, then really what we're doing is treating unequals equally. And that's an offence against this principle of justice. So this objection suggests that justice can't require us to apply a rule to individuals where that rule doesn't have equivalent effects upon their lives. This objection suggests we need another version, and that's version number 2. We treat equals equally when we give equal priority to equal levels of need. This is the idea. So what we need to do when we decide about prioritisation and things like that is to think of the person in the round. Think of how the health state affects their overall life and grade their request accordingly. Now, in the case of Veronica, the grading requirements don't allow for you to consider social and other considerations. So that means that we need to break the rule because the rule is unjust. There's no reason to follow the rule. So that's version number 2. Here's an objection to version number 2. And that objection is, why should we think that doctors are well placed to assess the general effect, the overall effect of a given health state on an individual's life? not something that doctors are particularly trained to do. It's not something that professional practice is always set up to allow. You might not know that much about individuals' lives. Furthermore, some patients are really good at communicating information, making a claim on their own behalf, maybe haranguing you, maybe harassing you, maybe providing you with reasons to either understand or respond to their specific case. If we allow those kind of things to affect how grading is done and whether rules are followed, what's going to happen is that a worse outcome is going to be produced overall. It might be good for some patients because they're good at working the system or because doctors respond particularly to their needs. But those patients who are more reserved, who make less claims on their own behalf, etc., will be penalised. And that penalty will not track a just difference between cases, a real moral difference between cases. So what we'll end up is with no effective grading system at all. It will just be madness, mayhem, chaos in the hospitals, and there'll be an inevitable slide down to the worst common denominator where everything's graded urgent. So if we don't want that to happen, we need to think not just about the patient in front of us, but about the effect of, disobeying the rules in general. So if we think that that objection is persuasive, then that will cause us to review our application of Aristotle's principle again. And I guess what we could say then is that we have to default to the rules. So we know that when we make rules, they're not going to produce the most ideal outcome for all cases, because rules can't be that responsive to individual situations. So following the rule is not going to provide the best outcome in all circumstances, but overall following the rules will produce a better outcome than having a situation in which either there are no rules, or there are rules but they're comprehensively broken. So there's no effective rules. So we need to take a hit on cases like Veronica in order to maintain the integrity of a system of rules that produces the fairest outcome overall. So that's version number 3. I'm not going to tell you which of these versions is the right version. I'd love to hear feedback from you. I'd love to sort of initiate a conversation about this. But I do just want to make a couple of observations about version 3. And those observations are this. There is probably, in at least some aspects of medical service, enough slack in the system and enough overall integrity in the system to allow some rules to be broken in some cases. And I think that we should trust that doctors do have the experience and wisdom to make those kinds of calls sometimes. So I would suggest that it can be acceptable to break rules or to make exceptions in exceptional cases, but that it's very important that doctors are aware of what it is about this case that they're responding to, what makes them think that this is a case where the rule shouldn't apply. And I have a few suggestions about things that could help navigate those pretty tricky waters. So there are, I think, 5 things that doctors should consider if they're contemplating rule breakage. What other options are there? Are there ways of producing the same or as good an outcome for the patient without breaking the rule? Because if there is, obviously, that would be better. That would dissolve the conflict. Secondly, and I think that this is a really tricky one, what's your motivation for wanting to break the rule? Are you responding to the needs of the patient? Is there a patient focus in your motivation? Or is there a practitioner focus? And practitioner focuses might take several different forms. You might be thinking, good God, this person is such a pain, and if I have to see them again in my surgery, I'm just going to refer them on, shunt them down the line, make them somebody else's problem. If that's your reasoning, then you're probably not behaving justly. You're probably just making it somebody else's issue to deal with. Or it might be that you're responding to the known practices of other colleagues. So you might know that other colleagues routinely break this rule. They routinely grade wrongly in order to benefit their patient. By buying into the practice, you might be exacerbating the problem rather than doing something good for your patient that you can justify. So if we can cut out the practitioner focus and focus on the patient focus, what aspects of the patient are you responding to here? Are you responding to a genuine health need that might be unacknowledged by the rules as they stand? Or are you responding to some idea about deservingness of this particular person? So in Veronica's case, are you responding to the fact that she's worked so hard and she's such a good kid and it hasn't been easy for her and you'd like to see her do well? Because if you're doing that, I think you're in murky waters. Because the flip side of using that as the basis for breaking the rule is that you punish the person who hasn't deserved what they've got and has got themselves into this terrible situation. So we don't want I don't want the health system to be used as a way of issuing punishments and rewards for people. It should be a way of responding to genuine need. Then there are costs. What are the costs of breaking the rule? And those costs might be borne on a number of different levels. What are the costs in terms of the overall health system? And is that your responsibility to police? What are the costs in terms of other identifiable individuals? So if you're dealing with a very scarce resource, there might be other patients who are going to be worse off for this rule breakage. Can you justify using that cost? Then there are systemic effects. How fragile is this system of rules? How much damage will be done to it if you break it? And then, and I think this is really crucial, what about trust? Is this little finessing of the rule going to undermine trust in the health profession or in the system? And if it is, that's a big consideration that should occupy quite a lot of thinking time. If it isn't, if it's quite consistent with overall maintenance of trust, then that suggests the rule breakage might be justified. And partly that's going to depend on two things. Well, on one thing, how you are going to execute this little act of rule breakage. So does this require you to falsify test results? Or does it just require you to apply a kind of liberal interpretation of certain categories that you could apply? If it requires falsification, the stronger the deception generally, the greater the opportunity to undermine trust. So think about the method of execution that will be required and be much more reticent, maybe even have a rule that says I don't falsify documents, but I'll be liberal when it comes to the category definitions, for instance. And I think that a good place to end my presentation and open the floor to you, and a good thing to keep in mind is how would you be willing to justify this rule breakage publicly? If you feel like you could stand by it and you have good reasons that you could present to others, then that's a good sign that you're on, safe ground. If you feel like it's covert, has to be done under the cover of darkness, then that suggests that you need to review some of these other things and really consider whether what you're doing is justified. All right, I'd love to see what you think about these issues. Don't know whether you talk